Welcome to Clinical Minute. Tamara is a 24-year-old woman who has come to see you after receiving a positive result from a home pregnancy test. Her last period was 7 weeks ago. She is in your office today to verify that she is pregnant and to discuss her options for termination. This is Tamara's third pregnancy. She has 2 children who are ages 3 and 1. She is currently taking college courses part-time while also working. Tamara and her kids live with her boyfriend, and money is tight for their family. Tamara tells you that she has considered her options, can't handle another baby right now, and would like to have an abortion. You begin by gathering a thorough medical history from Tamara and collect the following information: lab work to confirm pregnancy, determine Rh status, hematocrit or hemoglobin as necessary. Determination of gestational age by last menstrual period, LMP, ultrasound or physical exam. Tamara's lab work reveals no concerns, and gestational age of the embryo is determined to be 5 weeks. With these results, you counsel Tamara about her abortion options. Your clinic serves a predominantly rural population and does not offer surgical abortions. There is not a physician on site to prescribe medication abortion, and the nearest facility offering abortion services is over 100 miles away. However, as a nurse practitioner, you are able to offer a telehealth service with a physician at a remote affiliated office. Through a secure electronic communication system, the physician can review Tamara's medical records, view her ultrasound images, speak with her via video conference, and prescribe the medication for the abortion. Tamara expresses interest in this option. You explain the medication abortion regimen to Tamara. She will take the first pill, which is 200 milligrams of mifepristone, orally at the clinic. The second medication, 800 micrograms of misoprostol, will be inserted vaginally or buccally at home 24 to 48 hours later. With buccal administration, the pills are placed in the space between the teeth and the inside of the cheek. She will experience cramping and bleeding shortly after taking the misoprostol. There is a wide range of cramping and bleeding experienced by women who have a medical abortion. Most women experience bleeding heavier than a menstrual period, while some women experience heavy bleeding for several hours with blood clots the size of lemons. Other women have much lighter bleeding. For some women, the cramps are intense, but some women experience only mild cramping pain. Most women are somewhere in the middle. She can take ibuprofen or other medicines provided by the clinic to manage her cramping pain. In order to expel the pregnancy, the uterus must contract and the cervix must dilate slightly. The pregnancy will pass within 4 hours for over 90% of women, but it may take about 24 hours after taking the misoprostol. You let her know that this medical abortion regimen is highly effective for most women. In terms of follow-up, you will schedule a phone call with her in about 1 week to determine the passing of the pregnancy, or she can return for a follow-up clinic appointment in 2 weeks to check that she is no longer pregnant. However, she can call the clinic at any time if she feels she is bleeding very heavily or is worried and needs to talk to a healthcare provider. The FDA-approved regimen of mifepristone specified by the FDA in 2000 involved 3 office visits with a physician. Visit 1. Counseling and a 600 milligram oral dose of mifepristone. Visit 2, 2 days later for a 400 microgram oral dose of misoprostol. Visit 3, 2 weeks later for follow-up. Since then, evidence has supported the use of modified regimens that are as effective, less costly, and provide numerous advantages to patients. The current evidence-based standard of care for medical abortion includes a lower mifepristone dose of 200 milligrams, home administration of the 800 microgram misoprostol dose, which can be taken either vaginally or buccally, Only one visit to receive the first medicine is necessary if no in-person follow-up is needed. You may be told to return to the clinic for a visit to confirm that you are no longer pregnant. There are several ways to confirm that the abortion was successful. The clinic will tell the patient which method they use. Current evidence-based methods of follow-up after medical abortion include a clinical examination, ultrasound, a telephone interview with a low-sensitivity pregnancy test, a semi-quantitative pregnancy test, or quantitative serum HCG. Telehealth is the delivery of healthcare at a distance using technology. The use of telehealth has grown in recent years with varied applications, including in rural areas and for military populations. Some of the benefits of telehealth are reduced costs and travel time for healthcare providers and patients, increased quality of care, and improved access. Recognizing the potential to improve access to early abortion, Planned Parenthood of the Heartland launched a telehealth program in Iowa in 2008. Through this initiative, rural clinic sites that were not regularly staffed by a physician could provide medical abortion via telehealth. Studies examining this delivery model in Iowa have demonstrated that medical abortion via telehealth is effective at increasing access in rural settings and is highly acceptable to both patients and providers. Telehealth patients had comparable clinical outcomes to those receiving traditional provision of medical abortion. Between the two groups, success rates were equivalent, and the prevalence of complications was low. 94% of telehealth patients were very satisfied with the procedure. 99% reported that it was easy to both see and hear the physician, and 89% said they felt comfortable asking the physician questions during the video conference. Many telehealth patients have indicated that they actually felt more at ease with the doctor not being physically present in the room. With the introduction of telehealth in Iowa, the proportion of medical abortions increased. In addition, clinic patients had increased odds of obtaining an abortion before 13 weeks gestation, indicating that telehealth has the potential to reduce second trimester abortions. Tamara chooses the option of medical abortion via telehealth. You make sure that she understands what to expect. As required under federal law, you provide her with the booklet Medication Guide and obtain her signature on the patient agreement, which describes the FDA-approved regimen for medical abortion. Since the FDA clinical trials in the mid-90s, researchers and clinicians discovered more effective ways to administer the medications. You now have Tamara read and sign your clinic's consent form that explains the evidence-based medical abortion regimen that she will actually be receiving. You sign the patient agreement and record the serial number from the package of mifepristone in her patient record. Tamara then meets with a physician through a secure video conferencing system. The doctor reviews Tamara's records and ultrasound images and answers her questions. To dispense the medicine, the physician enters a password that remotely opens a drawer in front of Tamara. Inside are the mifepristone and misoprostol tablets. Tamara swallows the mifepristone immediately under the doctor's supervision. She will take the misoprostol within the next 24 to 48 hours at home. You provide Tamara with discharge instructions and confirm that she understands what to expect over the next few days. You tell her to contact the clinic if she has any questions or experiences any of the following: heavy bleeding with dizziness or lightheadedness, soaking 2 pads per hour for 2 consecutive hours, flu-like symptoms, fever or chills occurring after she takes the misoprostol, fainting, severe abdominal pain or severe cramping that is not relieved with ibuprofen or other pain medicines given to her at the clinic, or failure to get her next period when expected. You inform Tamara that her next ovulation could occur anywhere from 8 to 36 days after the abortion. This means that she could become pregnant as soon as a week after she takes the medications. You discuss contraceptive options with Tamara and let her know that she can start hormonal contraception immediately or have an IUD inserted after the abortion is confirmed. Tamara says that she would like to start on oral contraceptive pills. You provide a prescription for the pills and also dispense emergency contraception with instructions for use. Tamara thanks you and expresses her relief at not having to travel over 100 miles to have the abortion at another clinic. You schedule a follow-up phone call with Tamara in 1 week, and she agrees to call if she has any complications, concerns, or questions. If you are interested in implementing medical abortion via telehealth as part of your practice, start by checking your state regulations. Some states require that the physician be in the physical presence of the patient when prescribing medical abortion. A current listing of state policies on the provision of medical abortion can be found by visiting this website. Additional considerations for initiating medical abortion via telehealth include planning carefully and thoroughly, starting slowly with a few remote sites, budgeting for the costs of a secure telecommunications system and ultrasound equipment at the remote sites, staying informed of rapidly evolving communications technology, and planning for staff training needs, including special coding training for insurance reimbursement.